Now, there is a lecture by Dr. Renu Sinha, who is me, how to improve efficiency and productivity in ophthalmic operating room. So, I am Dr. Renu Sinha. I am working as a professor in RP Center, AIMS. For last so many years, I am practicing ophthalmic anesthesia. So, coming from a anesthetist mouth and words that how to improve efficiency and productivity in ophthalmic operating room, because once we are running 4 OT under general anesthesia, we see that till 11 o'clock, in one OT, 5 cases were finished, but in another OT, only first case is going on. So, improving the efficiency is a multi-step process. So, it should be done with maintaining a high degree of safety and achieving excellent visual outcome. We all know that operating room is one of the most costly and important area in the hospital, and it contributes 2/3 of the total revenue of that hospital. But expenses are also high. It is 40% of all hospital expenses which are coming from OR. So any improvement in the utilization of OR will pay enormous dividend to the hospital authorities. So the key is collaboration between all the workers which are there in the OR. It needs good leadership, flawless organization structure, collaboration, and process entails decision-making like distribution of resources, direction of role and responsibilities, and frequent performance monitoring. So there are different metrics. The first case start time, total case time, case cancellation rate, staffing cost, and turnover times. So don't assume that everybody speaks the same language. Everybody understands the same language is important. Because for a nursing staff, one's definition of turnout time is period from when the one patient is out of the room until the next patient is brought into the room. But for the surgeon, period from end of one case until the incision is made in the next case. So starting time 7:30 a.m. doesn't refer to the patient coming to the OT. It is at the time when the surgeon puts the incision. Surgical beds are also very important in the hospital, in the pre-operating room, in the operating room, and in the PSU. So many times patient is not shifted because PSU is full. So what is to be done? Post-operative instruction can be given when the patient is on the chair if the surgery is done under topical or regional anesthesia to prevent the PSU bed. Then in many places, incorporating the efficient dilating protocol was done to reduce the time because many times mydriasis is not good, so the case is delayed. So they combined the dilating drops, tropicamide, NSAID, and proparacaine for the easier dilation of the eyes, and it can cut the cost of putting the repeated drops. Universal needs lead for monitors are also available, so it should be kept in the pre-operating room, operating room, and the PSU, so that once you are shifting the machine or monitor, you can shift only the machine or monitor, and you have the universal lead there. It is not needed in every patient to put the IV drip. You can put the IV line and put the saline lock, so that the patient can be shifted in the lesser time. Then smart OT equipments are also available. OT table with remote, with memory. So it is memory 1, 2, 3. If one surgeon is operating, just put one button and the table will be at that height and at that angle. Similarly for the operating chair also with the memory. For that surgeon, the thing is fixed, surgeon 1, surgeon 2, surgeon 3. So the operating chair will be at the same height for that person. In many places where they are running 2 OR, there is wireless doorbell put in the hallway. So timing of drape, the nurse will press the bell, so the other OT will know that how much time will take for that case. And when the IOL is placed exactly after 3 minutes, patient should be draped in the another OT to reduce the time. So the efficiency will depend upon whether it is individual practice, government hospital, or corporate hospital. If per day less than 10 cases are there, 1 OR is sufficient, 10 to 20, 2 ORs, and if you are doing more than 20 cases, then more than 2 OR may be needed, and accordingly staff will be there. The other thing is said that organization of the OT. Keep the layout of each OT same, so that the staff will develop a cognitive reflex, so the things will be less delayed. Sometimes on the right side the thing is there, sometimes the left side the machine is there, so it is difficult. Ensuring standard equipment at the same place in the OR along with the organization of the supply table is also important. If the supply table is organized in the same way again and again, so if the OT staff is taking leave, then the another staff can do the same stuff in the same time. So training of OR staff, pre-op nurse should be trained how to position the patient on the OR table. Scrub nurse should be trained how to prep and drape the patient for that type of surgery. And the assistant should know how to remove the drapes at the end of the case so that the lesser time will be taken. Post-op education should be started early in the clinic, so it will be not done in the OR. Nurse should just remind the post-op instruction, and these post-op instruction can be given also to them. One should aim that in the PSU, discharge should not be delayed by more than 15 minutes if patient is not getting any sedation. Anesthetic setup should also be good because many a times for the children, a good competent anesthetist is needed to do the case early. So necessary drug and equipments, trained technicians, good quality machine and resuscitation cart, and evaluation of the patient before and after the surgery. Analyze the instrument requirement because need of instrument will depend upon the type of surgery. So 8-minute cataract surgery will require more sets than the 12-minute surgery. 2 OR will require more sets than the 1 OR. And if there is delay because of the non-availability of the instrument, it's worth purchasing the another set. And all sets should be complete. So OR efficiency benchmark, this was the table which I got from one of the things. So there are 3 levels where the constraint is there, material sources and human resources. These 3 places one should work to reduce the OT time and to improve the efficiency. So it can be divided into 3 types. Patient entry into the OR till the incision, during the surgery and end of the surgery to the patient out. These 3 areas will have different types of problems, so they should be tackled one by one separately. So bottleneck are mainly patient did not arrive on time, nurse do not have enough time to admit, waiting for the instrument, and PSU is full. So there are other issues also. If the patient is admitted in the ward nurse got involved in some other patient and patient was not shifted. HA is busy in the mobile and he doesn't know that the case is over. Lab reports didn't reach on time. Transport guy failed to deliver the equipments. Faulty OT machine. And nowadays in government institute, JSS and Ayushman Bharat, which takes more time because they need more clearance. And certainly because of the surgery type, AMG is not available before 10 or donor cornea will be assessed at 11 o'clock. So patient schedule should also be important. One patient in the OR and one patient ready to assess the mark. Predictable and shorter cases should be done first in the list so they will go home. Early admission should be there, 30 minutes to admit and prepare for the procedure. And if they are shorter surgeries, then 3 to 4 patients should be admitted before starting the first case, so there will be no delay. There is electronic scheduling system is available which will help the busy ophthalmologist or any surgeon to schedule their cases. And these are the scheduling platform which is available for iOS and Androids. So IoT medical devices are there now, AI is there. So end-to-end patient portal to facilitate effective communication between patient and healthcare organization. Start from the time of appointment till the recovery. Send reminders to the patients before their admission. And this will improve patient activation in their own care. So it reduces the OR delay with limited staff. You can post online pre-operative and post-operative surgical guidelines. Less verbal exchange is there, so less time is involved. And save healthcare staff vital time to do other productive work. You can also see the doctor's utilization of allotted time. So there are integrated OR time app also, which will put just like there, that total allotted time and remaining time, which will make staff more aware and what to be done if there is delay. Open communication with staff is also important. Weekly team meeting should be done. One should not be the total boss to share the vital information about any issue that arises. Ask your staff to document and communicate the problem and turn feedback into actions. So to conclude, to have an effective OR, one should need a visionary leader, competent surgeon and anesthesiologist, a well-trained staff, and now is time to incorporate web-based services, and one should learn from experience because each and every place the problems will be different, so one cannot say that it should be done like this or it should be done like that. So it should be tailor-made, and regular feedback from staff, from anesthetists, and from the patient should be taken to have a effective OR management. Thank you. So, we have how many minutes? 2 minutes. Dr. Arshad, do you want to tell something about ultrasound guided block? Peribulbar? Okay. So, anyone else, if want to ask something? So, I will say that it is said that ergonomics of the OT is very important, but it is not every place, because in our place we have OTs not adjacent but in front. So in one OT, the table is on the surgeon is on the left side, assistant is on the left side, anesthesia machine is on the left side, but in another OT, it is on the other side. So it should be tailor-made. It is well said than done. Surgeon should see, and it should be with the anesthetist and surgeon's collaboration to have a better outcome. I will ask Dr. Tanveer, did you see any phenylephrine-induced pulmonary edema? Okay. So, anyone else want to contribute? Dr. Shalini? So, Dr. Suman said about dexmedetomidine intranasal. So, I was reading about the efficiency in the OR. So, I saw one thing that one surgeon said that they had shifted to sublingual medication to reduce the time. So, sublingual is very, dexmedetomidine is tasteless. So, the patient acceptability for sublingual dexmedetomidine was better than intranasal, and then they shifted it to those. So, the one problem with dexmedetomidine is that many times if you are using the adequate dose, it leads to sedation and the discharge of the patient is delayed.
We've been using Dexmed for almost a decade now at Netradama. We started off with loading dose and an IV titrated doses of say 0.25 micrograms per kg, and we went on to maintenance of 0.25 mics. Then we got the confidence to shift to intranasal Dexmed after having quite a bit of confidence. Even in beta block patients were very comfortable. So now intranasal Dexmed we are also using at 0.5 mics. To control white coat hypertension, so that we can allow the ophthalmologist to give the block and not cancel the case on table. So not only for sedation, even a smaller dose is being used for reducing blood pressure on table.
Okay.
But it requires about 20 minutes to have onset of action, but it's amazing that we do not cancel any cases anymore. And like you said, ma'am, intranasal Dexmed we are using as pre-medication for children too. We do not have experience with sublingual as of now. So I'm assuming the absorption may not be very predictable in a sublingual route. I'm yet to get experience in this.
Okay, thank you so much.
It almost has the same bioavailability as intranasal, more than 90%. Unlike oral, which has a bioavailability of only 75%.